Good afternoon, everyone. My name is Shannon Kupka. I'm a project manager working with the nursing home teams in New Mexico from Health Insight, and I'd like to welcome you to our half-hour Hot Topics series, the first of 2019. These webinars are designed to provide you great ideas to improve behavioral health and reduce antipsychotic use in a 30-minute time frame to accommodate your busy schedules. They're brought to you by Health Insight and Qualis Health and sponsored in partnership with the New Mexico Healthcare Association. So we are very excited about today's presenter talking to us about the person behind the diagnosis. Dr. Matt Stricherz is a 1973 master's degree graduate from the University of Guam and a 1976 doctoral graduate from Texas Tech University. He is employed as the psychology supervisor for the Adult Psychiatric Division of the New Mexico Behavioral Health Institute in Las Vegas, New Mexico, is a psychologist in private practice and adjunct professor at New Mexico Highlands University in the clinical psychology department. He has published multiple research articles in the field of psychology, disaster mental health, suicide, violence in the workplace, death and dying, psychotherapy, and alcohol and drugs, in addition to many presentations of papers within his professional field of psychology. His background includes community and consulting work in nursing homes, assisted living centers, and hospice settings. He is a 30-plus year Navy veteran and embraces service in a global health perspective. Dr. Stricherz, you may get started.
Well, it is indeed a pleasure to be here. I love people. I love diagnoses, but I like to keep the two of them separately when it comes to actually interacting with people in a variety of settings. So we're going to talk today about the person behind the diagnosis. But as we begin, I want you to know that the contents of the presentation today are solely limited to the opinions from my experiences and do not reflect the opinions or practices or endorsements of the New Mexico Department of Health and NMBHI. Those are my employers. The content of this presentation is from the public domain or the direct results of my research as well as working in the field in different areas. I also do not have any financial disclosures to declare. What I want to begin with is the caretaker. That's the I-thou of patient care. This is an extremely important part of my training when I was a professor of nursing at Texas Tech University. And I'd like to just remind all of us that the caretaker and the I-thou of patient care is when two people come together. It's our job as caretakers to establish the contact between us and the other persons. Now, for some of us, we'd never just have another person in the interaction. We interact sometimes with 5, 6, 7 other people when we have a contact with the family. It's sometimes difficult to have the same kind of contact with each of those family members. We also have contact with other staff members, and it's important that we have consistency in how we interact with all people. It's our job as caretakers when we're working with our patient population that we respect the patient's struggle. One of the things that is sometimes tough for us to remember when we have a difficult patient, a challenging patient, or a patient that's very hard to be able to manage is to remember it's the disorder that is the issue and the patient's not a bad person. Sometimes for those of us that are in a supervisor role, we have to remind the others that we work with that it's the disorder and it's not the person. The caretaker's job is a simple job, and that is to remain neutral while the patient heals and exists in their actual being. Our job is to be able to remain neutral. Our job is to keep our awareness to ourselves in that process. And the way we do that, and many of you have already mastered this task, is to have emotional and behavioral control so that we can create consistency in our client's life, our residents' life, our colleagues' life, and in overall our patients' lives. It keeps us as the caretaker in a vigilant and empathic stance as we try to remain with behavioral and emotional control. When a person has a particular kind of disability in our nursing homes, they really do often attend to our nonverbals more than the verbals that they hear from us. And one of the things that I find helpful is to always question, was this interaction with this patient or this person or with this family group, was this biogenic? Did it add life to our relationship? Did it add something positive to the person? And when I ask that question, if I think, well, this was a little bit biocidic today, how do I change that for the next time I interact with these same people? And of course, biogenesis is what we want in those relationships. So when we look at the person behind the diagnoses, we encounter them right where they're at this particular time in their life. But the person behind the diagnoses in our homes, even in that process, while they're in a dying mode in a hospice, it's important to, if we can, find out what were their developmental milestones. We may be able to use that in order to assist them in their journey. What was their biological life like? So the question is, what were their gifts in life? And we get those informations from the family, from the charts, by observing. A person that has achieved a state of cognitive deficits in their elder years still can show some of their gifts that they had in their life. And then what were their trials and tribulations? What happened in their life that sometimes presents in their interactions with us as caregivers that's separate from the actual interaction? What do they bring in that's challenging in this interaction? What has happened that is part of their personality style? What was their overall personality like? What was the general personality that their family saw? Did they have a personality disorder that was diagnosed? Sometimes that is helpful. An example of that is I was in an interaction where the physician made a comment to a family that the father was going to be sent home for care by the family's mother because she was such a warm and wonderful person. And one of the family members asked the physician if they could have the mother step out and talk to the person for just a moment, talk to the physician. And they all said to the physician, "You don't understand our mother. She's mean, she's harmful, and it's because of her mean personality that our father has gone into a shell inside of himself." So sometimes it's nice to know what the overriding personality has been. The physician was quite surprised by that and did work with the family in getting a better sense of where the person could be and what kind of a unit. What are the patient's accurate memories? If you can verify a memory, then during tough times, you can use that memory perhaps to help refocus, redirect the patient. Many people present with much false memories because of the confusion they have because of their disorders. And what puts a smile on the patient's face? And because patients in the elderly stages are often non-verbally oriented, they will mirror the smile or the frown on our face if that's what we present with. And also what puts a frown on their face, and how do we match something in their memory that will help get rid of that frown verbally and non-verbally. And I think a very important area is, what was their native language? And as a caretaker, can we learn just a greeting in their native language at times? going to talk very briefly about a diagnosis of dementia. Psychologists and psychiatrists often will use the DSM-4 systems to describe a mild or a major neurocognitive disorder. This is one of the most common diagnoses we see in the chart. Simply, the diagnosis means this person is having some problems with memory, executive functions, etc. Also, it's one of the major diagnoses we find in the elderly. Depression or dysthymia is one of the other common diagnoses we find in the elderly. Generalized anxiety or related anxiety to decline in the cognitive or mental status. People become aware of how they're changing, and that in itself will create anxiety. Reassurances, of course, are wonderful. And then we have sleep dysregulation. And one of the things that we know about sleep dysregulation over time, even in the elderly, demented populations, will generate often psychotic symptoms. And then eating dysregulations for a variety of reasons, depression, problems with sleep, or just such a bad affect that food no longer gives them joy. And when sleep takes place, eating gets off, or they have a mood dysregulation. All of those types of things indicate that ongoing changes are taking place. All diagnoses that we take a look at in the field of psychology, we have to ask three questions. Was this caused by a medical condition? Was this caused by a medication or substance? Or is this the real deal diagnosis? Is what we're seeing the actual diagnosis, or is it being masked by a physical condition or possibly a change or new medication? With new symptoms or changes with your patients that you've known for a long time, then we have to ask the question, have you ruled out delirium and its causes, medical conditions, and also take a look at the MAR. What's the change been? Sometimes the patient knows the difference, but we're not able to actually get the feedback from the patient. All three, persons with TBIs, mental health effects, or substance effects, can have mood dysregulation, energy dysregulation, lethargic types of moods where they just do not seem connected anymore with those things and joys that they had in the past. Cognitive changes, thinking distortions, and the confusion that comes from not recognizing who you are, not recognize the family, those become very important to the person and will often cause behavioral dysregulations itself because they no longer find the place, the person familiar to them. And then we have reality distortions, and these are psychoses. These are the hallucinations. These are the delusions. These are the other kinds of things, the adding events, adding realities, which aren't really psychotic, they're called confabulations. And when there's been persistent or transient changes in the brain from medication or TBIs or the mental health effects, the tough thing for families is they expect a person often to be able to change and get back to what's their normal state. Common diagnoses we see with the elderly are the depression, dementia, anxiety, feeding disorders. And one of the things when it comes to looking at that person who's got psychoses, there are times in which a new hallucination, fears, or paranoia may be an actual sign of something else. Perhaps conflict with the family, perhaps a sign of abuse. Sometimes it's a healthy way of that person communicating something to us. And sometimes those are indeed a part of a diagnosis called schizophrenia. And people that have bipolar, manic depression are very common in the elderly, and sometimes given because the mood swings and everything have not been regulated correctly through interactions with staff, counseling, and or possibly medication. And one of the things that we know now with some of the people that come into our nursing homes is we can recognize post-traumatic stress disorders and the syndromes a lot more frequently than we did in the past. And it is the recurring of internal trauma that's actually being presented. The person behind that diagnosis often has never had a chance to resolve the earlier trauma. There are all kinds of things that cause normal decline in aging. Okay, and these are just some of the things that we have. Vascular kinds of changes, the Alzheimer's, the infections that sometimes do not actually get identified right away. I can think of a place where I worked with in the past where somebody just had come into the nursing home. It was missed that they had a urinary tract infection from the hospital, then sent them. 3 months later, they weren't much better. And one of the aides was doing some charting and found a sheet of paper that was misfiled and discovered that what needed to be looked at was the infection. And with treatment, then the person no longer needed the nursing home. So that's something we don't want to miss. Depressions, pseudo-depressions, or pseudopsychoses that look like depression. What's the real person there? What caused that decline? What kind of toxins or nutritional deficits are there? Sometimes families will ask us, hey, don't they just need a B12 shot and they'll be okay? And strokes and multi-infarct kinds of issues, or sequential TIAs and mini strokes. I was interacting with a family once where the wife asked, could we just give them a brain transplant so that they could be their old self and come home because they miss them so much at home? The changes don't always make sense to the family, and they look often for the magic. And sometimes they don't really want the reality because they don't understand the reality of what has been going on with their loved one. Dementia, the mild and neurocognitive, major neurocognitive disorders are identified by observations of the nurse, the aides, the tech, the family, the visitors, sometimes the medical status. When there is a change in that person that is now noticed, probably another mental status has to take place. Occasionally new imaging has to take place. And now we have an issue with the patient if they know that something has happened to them, and how can we connect with that person and use language that makes sense? How can we work with the family so that they can maybe explain some things to the patient? Blood work has to be repeated, and some patients don't like the blood work. And how do we remain in a good place when we ask them to give us more that will be helpful to us in working with them? The psychological assessment, the cognitive status exam, is really important consistently. Sometimes we have to do neuropsychological testing where it takes some special kinds of tests. The most common neuropsychological testing has to do with a simple mental status exam. What's your name? Where are you? And things like that. And when there's a drastic change, reinforcing the correct answers to those things sometimes help, but when they don't seem to help, now we have to take a look at the development of the issue that the person is experiencing. And of course, pharmacological evaluations whenever new medications are given to the particular patient. And this is one of the tough areas for the family. A family sees the symptoms, sees the changes, and wants to explain so that the patient understands their symptoms. What is the memory loss? Does the patient know that they have a memory loss? Is it okay to let them know, to remind them that, well, today your memory doesn't seem to be as good as yesterday? And if you'd say that to them, how do you say that in a good way? When they get stuck on a story or an event, that's an indication that's the perseveration is maybe showing that there's a change in their overall mental status, and the course of the disorder is getting of more advanced. When they ask her, what was that word, name, car, or color? How do we handle that? What hints do we give them? Do we ever give them cards with common questions so they have the answer, and then remind them, look at your card? When they have roller coasting moods or behaviors, do we let them know, well, yesterday you were calmer. Has something happened that I need to know about? When there's a change in orientation, rapid or gradual, then they wonder, do other people see that? They keep contact of that, and they often aren't able to tell us that. And then, of course, the changes in hygiene, language, gaze, sleep, and their overall changes in mental status, including the time of day or place or room, where the cafeteria is, where the bathroom is. Do they know those things? Do they still recognize their name? Can we use their name to help them remember certain kinds of things? There are a variety of interventions that can be done. And most all of us at this time in our lives and careers, we have had many experiences with challenging interactions and behaviors. That started in childhood because our parents gave us some challenging interactions, and we learned how to traverse the developmental goals and needs that we had. Now with our patients, when it comes to non-symptom based consistency, there are several things that we know. When certain kinds of behaviors take place that are maladaptive, challenging, and inappropriate, a consistent approach with them seems to be able to help change that behavior. If we are consistent with them, we have the same space with them that's shared with a smile, a calm manner. Do we always use simple sentences? Do we agree or reframe what's happening with them rather than arguing? Do we give them the gift of thank you? When somebody says they're feeling really bad, they're missing their spouse, do we say, thank you for sharing that? And what did you see on TV? Then kind of a redirection. It's the gift of the thank you. There are times in which the gift of the thank you, that when it takes place, it'll reorient a person back because they have the texture of the interaction that you're being good to them, you're being understanding, and you're listening. Is it a routine noise or is it a manageable noise in the environment when a person interacts with you? When their room is noisy, when the halls are noisy, are they able to communicate with that background noise? So we have two kinds of background noises. We have the background noise of the interaction between the caretaker, how he or she is presenting themselves, and the room and the place where the interaction takes place, whether or not it's too light, whether or not the TV is too noisy, and those kinds of things. We need to be consistent in our interaction as a human being with the other person. And we need to get rid of the tyranny of the deride. And that, for some patients, comes, deriding is just a little put down. Oh, Mr. Jones, you're so silly. Well, some people don't mind being called silly, and some people say they don't like me. That feels bad. Or that's a very interesting thing to say. Nobody said anything like that before, Mr. Jones. Or, that's not a very good question, and your behavior is not very good. The tyranny of the deride. The deriding changes the relationship, the I-thou relationship. So it's kind of good to always phrase things in a positive way. And I have always encouraged the use of note cards where we keep track of those things that we know help redirect a patient into a good way. And then we have symptom-based issues. The interventions are generally to affirm the symptom, to acknowledge the patient. I know you're missing your wife. I've missed my mom. Tell me one thing you liked about it. or my wife, or whatever it might be. Create distractions when there is unacceptable behavior or there are personal space violations. A couple of things that we know when there's inappropriate sexual behavior, space violations, it is especially important for this kind of symptom-based intervention that we maintain time after time the same kind of face, body language, and words that match. Frowning absolutely is definitely appropriate so that the person understands the nonverbal cues saying something happened that's not acceptable. And when it's followed by a no, stop, don't touch me, or I don't like that, and then the redirection, it does set a good place to know that the nonverbal is going to help the patient know that they need to change their behavior. It takes multiple times at times, but the consistency gets rid of the confusion that comes from by not knowing. Sometimes the patient doesn't know who we are. They forget that we're a caretaker. They may imagine that we're a significant other in their life, but we want to be straightforward with our interaction with them, with our nonverbals. Nonverbals are a very important part of the I-thou relationship. Consistent facial and verbal and nonverbal when limit setting is so important. One of the other things to consider is that in setting limits, that's the most likely time that healthcare workers will get struck. There's some good research on that. Setting limits with consistency over time with persons that have cognitive deficits help them understand the limit. Sometimes if a trigger is identified, you can move her and disengage the trigger, move her and disengage the person in different parts of their nursing home facility, in their room or otherwise. One of the things is we always want to remember the issue that's worked on the past. Write it. I like to write it on a card when I'm working with multiple patients. And I also want to pass on to my colleagues what worked in the past. So I'm hoping that you all could hear me, and now would be a time that we can go to questions. Shannon, do you have it?
I do. So what I'm going to do is give folks a minute or two to think of, well, probably 30 seconds more like it, to think of any questions that you might have. And you are welcome to enter these into chat, or if you'd like to raise your hand, Kelly can go ahead and unmute you if you've got a longer question and your fingers are tired of typing. So right now we had one comment in chat, which was to your point about maybe the family member who presented one way as calm and loving, and then the family shared a very different experience of the mom. And somebody commented also that they had that as well in their building.
Excellent.
So
thank you.
You're welcome. So please take a moment and enter any questions that you might have in the chat, maybe something going on in your building that you'd like to ask a question about. What I did in the meantime is mention where this presentation and our other presentations on Hot Topics can be found in our website so that you have this. So give you another probably 10 to 15 seconds for any questions that you might have.
And while you're getting questions, I do apologize for evidently was a technical difficulty that I have in presenting, and I apologize for that and hope it was not too distracting to anybody.
We are used to dealing with all sorts of questionable technology in the nursing home world, aren't we? So let's see, we had a couple of folks comment that they really appreciated and enjoyed the presentation, so thank you very much. We had Lori mentioned she has a participant who turned into a vegetarian once she had dementia, and her husband's in a conundrum due to never having had to cook or prepare meals for a vegetarian. Could this be temporary?
Could this be temporary? Was that the question?
Yeah.
Well, one of the things that some of the new research is showing, especially with patients that have some altered mental statuses because of nutritional deficits. Vegetarian, depending on the kind of vegetarian diet a person uses, may actually make more problems because there may not be total proteins and things like that. One of the things that I have found in the past is I go to my kidney specialist and find out what they're finding with some of the specialized foods for kidney patients that are on dialysis that gives complete proteins as would be needed, as well as the full range of all the nutritional benefits that they need. So I use some of the resources that would be available. Now, might that change? It certainly might change over time. And when I've had similar kinds of issues, not specifically somebody becoming vegetarian, but somebody developing an allergy to food, then I have to shift gears. The person who is the designated patient is not my consulting concern. It is with the person. How can I find a good resource to assist them in how they interact with that particular family member or friend? So it's a great thing. Many people would say that vegetarians have better mental health. We do know that they tend to have more issues with weight, maintaining weight, than people that do eat some of the other proteins in their younger developmental years. There's not too much information out there in the elderly population. That's a great question. I hope that helped a bit.
Okay, thank you very much, Dr. Stricherz. And then we had a question from Leah where I think slide 11, when you were talking about your approaches, you had mentioned the word questions, and Leah wasn't clear if you were encouraging questions as an intervention or maybe implying it was not a good approach.
Let me go back to slide 11. I gathered this was the slide.
I think so, or maybe it was 12 where we were talking about symptom-based and non-symptom-based approach. Not sure. I can see. While you're looking for that, a couple more comments. Again, Lori mentioned, yeah, that it not necessarily the nutritional aspect of vegetarianism, just that the person completely changed their tastes. Yep. And Allison mentioned that her mother's decided she no longer likes fish. She used to always love fish, now won't eat it. And her dad, who used to love spicy foods, can't eat them at all. So yeah, the taste changing, I guess, as a result of the dementia was mainly the comment. So
let me comment on fish with some of the newest research on farm-produced fish instead of wild-caught fish. There's actually differences in the nutritional value, and some people can react better to the wild-caught fish rather than farm-produced fish because the nutritional value has changed, vitamins, minerals, and textures also change in those. I've read several research projects on that recently because of the shift in how farm-produced fish are made. So that might actually be what she's responding to rather than a wild-caught fish.
Right, and Leah, who is a dietitian, mentioned that it's very normal with cognitive impairment that there are sensory changes, and age also changed tastes. So
thank you, Leah.
So I'm going to actually, unless there's anything that is, and I'll also make sure there's not any chewing problems. It's common for people with dementia to not want to wear their dentures because they don't understand the foreign object in their mouth.
Yes.
So yes. Because we are a little bit over due to our technical difficulties, I'm going to say if you've got any burning questions, go ahead and please enter them for any final comments. What I'd like to make sure you all know is that this presentation will be posted to our website in a few weeks, and I encourage all of you to check out our posted webinars there on our nursing home library. I put the link into chat. Please share this with any of your colleagues who couldn't attend or use it to in-service your staff. And if you'd like some suggestions on that or need some assistance, please feel free to reach out to me.